Hello. This case involves extraction of an internally resorbed tooth and replacement of the tooth with a small diameter implant and crown after grafting the socket with freeze-dried bone. There was limited space because of the small facial lingual width of the alveolar process, so we used a small diameter implant because we didn't have enough facial lingual space for a root form implant. You'll remember small diameter implants are any implants less than 3 millimeters in diameter. So you can see the internal resorption. Here's the small diameter implant. This is always a difficult extraction because you know the tooth is probably going to fracture at the site of the internal resorption when you're extracting it. It's funny, when I'm placing implants, I often place the implant at the time of extraction if it's a single rooted tooth. In this case, the extraction was so difficult that I didn't feel like it was appropriate to place the implant at the time of extraction. But many times the extraction, especially in a endodontically treated tooth or an ankylosed tooth or internally resorbed tooth, the extraction will take longer than the placement of the implant. You can see again the internal resorption. Very important to administer painless and profound local anesthesia. You can watch the videos on mandibular and maxillary painless and profound local anesthesia. So you can see here's the internal resorption. Just like a beaver cutting through a log, it's just worked its way almost all the way through the neck of that tooth. So I'm administering intraligamental local anesthesia, and this is with sit nest 4% plain in a 30 gauge needle, and you turn the bevel toward the tooth in the sulcus and apply pressure for about 20 seconds. Anytime I'm extracting a tooth for orthodontic purposes or a tooth like this, I always mark the tooth. I know which tooth it is, but I don't want to have to think about that, so I mark it just to be sure. Now, this is a hot tip. I'd like to elevate the tooth mesial and distal before I extract it, just to loosen it up in the periodontal ligament. So if you've got tight contact on both sides of the tooth, you don't have any space to elevate it into, and so you really can't elevate it. So I'm cutting between the adjacent teeth with a thin diamond burr just to create a space that I can elevate. Now, it ended up not removing the tooth, but it did loosen the roots of the tooth in the socket so that I could end up removing. If you can get a little movement before you try to extract the tooth, that's always helpful. I rarely try to extract a tooth without first trying to elevate it mesial and distal. We're trying to preserve the facial bone, which did not work out in this case. I'll show you here in a minute, but we're trying to preserve it. And if you could take the tooth straight out of the socket, I could probably place the implant at the time of extraction. So you can see we're moving the tooth, but I'm thinking it's probably going to fracture at the line of the internal resorption. I've got pretty good movement. I'm going to make an incision, and the reason I'm making this incision, I want to be able to visualize the alveolar crest because I'm hoping I can place the implant at the time of extraction. And if I do, I want to place the threads of the implant at the alveolar crest. So I'm just trying to unscrew the tooth, and it does fracture at, you can see the tooth right here. It fractured at the line of the internal resorption, which is to be expected. Now, I had my videographer video the whole thing because extracting a tooth can be a time-consuming thing. If you've got a high-volume practice, probably the most unpredictable thing you'll do is extract an ankylosed, endodontically treated, or internally resorbed tooth. So I'm going to try to extract the rest of the tooth with the easy extract. So I start out with a headstrom file, and I'm just opening the canal so I can drill the easy extract drills into the canal of the tooth. So this doesn't work. So I'm showing you real dentistry in a real office. And what I go through the same things you go through. You just never give up. You've got to get the tooth out. But sometimes it can be complicated. So I'm reflecting a flap to see what's going on the facial of the tooth. Now this is a very small, long shank round burr, trying to dissect the root into two parts. Now remember, I elevated it to begin with. So my hope is it looked like the entire tooth was moving in the socket, which makes extraction of the roots easier. So I'm hoping that's what happened, and I've just got to create some space. I'm going to try to divide the root into two parts and elevate them into the space I'm creating. It's just the smallest long shank round burr. So the good news is, in the mandibular anterior region, I'm not worried about drilling into the inferior alveolar nerve. There's not one in this section, so we're not worried about that. So I'm using a periosteal elevator and just trying to elevate the mesial and distal of the root. These are a pain to extract because you know you're going to take it out in pieces, but I need to extract the entire tooth in this situation. Now what if I couldn't get this piece out? Sometimes you've got to take a round burr and just drill the remaining part of the tooth out if you're placing an implant. Now if I wasn't placing an implant, especially if it was in the posterior part of the mouth, I might just sleep the root. I would take most of it out and I might leave the apical 1/3 of the root in place. But in this case, if I'm placing an implant, I really need to extract the entire root. You can see this remaining part. Now when I'm doing this releasing incision, when I make the incision, I want to reflect the facial 1/2 of the papilla, but I want to leave the bulk of the papilla in place so I can suture the flap precisely back to the papilla. Again, I'm trying to elevate that part of the root. I'm going to go down and remove some more of the apical part of the mesial of that root with this small long shank round burr. You really ought to have some long shank round burrs in case you get into this type of situation. A normal shank round burr won't do it because you hit the handpiece on the adjacent teeth and it won't let the burr get far enough into the socket to do any good. So here it comes, root tip. Now we've extracted it, so what have we got? Well, I'm not going to place an implant at the time of extraction because most of the facial bone is gone. So I'm going to graft it, and when I graft a socket, I always do this with multi-rooted tooth. But in a case like this, I'm going to do it with a single rooted tooth. I graft the socket and let the socket heal for 3 months at least before I place the implant. So I'll go through that again. If it's a multi-rooted tooth like a molar or a multi-rooted bicuspid, sometimes you can place the implant at the time of extraction with a 2-rooted bicuspid. If it's a multi-rooted molar, I personally always graft the socket with either platelet-rich fibrin and freeze-dried bone, or sometimes I'll just use freeze-dried bone if the patient doesn't have good veins and you can't draw blood easily to fabricate platelet-rich fibrin. Then once I graft the socket, I'm going to let the bone heal for at least 3 months and then come back and place the implant. Now, I personally don't load implants at the time I place them. Even if I placed an implant at the time of extraction, I don't load them for 3 months. I want that bone to osseointegrate into the implant. I grew up ranching in West Texas, and if you put a fence post into concrete and you wiggle that fence post before the concrete sets, you're going to lose the fence post. So I think the same thing applies to implants. A lot of times they're loaded at the time of placement. And if you can make that work, more power to you. I'm for you. But I see implants in my practice that have been lost, placed in other practices and loaded at the time of placement. And my feeling is if you place the implant and put a provisional crown on the implant and the patient is a clincher, they can wiggle that implant in the socket before it osseointegrates, and it heightens the chance of you losing the implant. So I don't do that. I give them a flipper if it's in the aesthetic zone, and they wear that for a few months, even if they're kind of complaining about it. It's just life. I had a flipper right here with this implant, and I never wore it, but I had it. If I was going out on the town, I could put it in, though I didn't have a space, but most of the time I didn't wear it. So my wife always said, Steve, do you mind if I sit on this side, the right side, if we're eating, so I don't have to look at that missing tooth? But anyway, I don't load them at the time of placement. So this is freeze-dried bone. I'm going to pack that in the socket. Now, my favorite, if a person has good veins, is to draw blood, spin down platelet-rich fibrin, and mix the platelet-rich fibrin with the freeze-dried bone and use the serum as the wetting agent. You know, platelet-rich fibrin enhances healing. This patient did not have good veins, and so I wasn't able to do that. So I'm using just plain freeze-dried bone, and that works well too. So this is a resorbable collagen membrane. We place that over the grafted bone in the socket. Now, why do you use a resorbable collagen membrane? You want bone to grow in the socket and not soft tissue. So the resorbable collagen membrane gives the bone about a 3-month head start on the soft tissue, because the soft tissue grows faster than the bone. So you want to give the bone a head start on the soft tissue. So this lasts about 3 months. So I'm cutting the corners off and contouring it. I want some under the soft tissue. I want to cover that whole facial of missing alveolar process. I'm going to cut one part that goes over the top and one on the facial. Now, in this case, I'm going to use 4-0 gut suture because it's pretty delicate stitching. You know, remember, I left the papilla so I'd have some soft tissue to suture into. There's no magical way of suturing. You just want to close it up so you've got, you know, the tissue is covering as much as possible the resorbable collagen membrane. Now, I do a lot of implant placement and extraction where there's not primary closure of the flap. You've just got either platelet-rich fibrin or resorbable collagen membrane over a fairly significant section of open flap, and that works real well, either one. So I don't want to reflect a lot of tissue just to get primary closure, because in my experience of doing this 40 years, that's not of consequence. You know, if you've got part of the flap does not have primary closure, as long as you've got resorbable collagen membrane or platelet-rich fibrin under the tissue covering the graft, it's going to heal just fine. I know some people say you need primary closure in these cases, and you have to go down and reflect all the way to their chin to get the tissue to cover the graft site. I've never believed in that because I want the blood supply. So I'm going to cover as much of the graft site and the resorbable collagen membrane as I can, but I'm not going to reflect all this tissue and all the releasing incisions to try to cover the whole thing, because in my 40 years plus years of doing this, it heals just fine as long as you've got a resorbable collagen membrane or a slab of platelet-rich fibrin over the graft site. So when I'm suturing, I'm going to go 1, 2, 3 wraps away and one toward me, then another one away, and I'm going to pull each one. So 1, 2, 3, pull, one toward me, pull, one away, pull. Now you can go just 1, 2 away and pull, and then one towards you and pull, and then one away and pull. Okay, so you can see the graft. This is a provisional flipper. This after 3 months of healing. So we've got, adequate facial lingual bone, but not enough for a root form implant. So it's all about surface area. So you either want a wider implant, larger diameter implant, or a longer implant. So in this case, we're going to use a longer small diameter implant, which again, small diameter means it's less than 3 millimeters in diameter. So I'm going to anesthetize the tissue. The key with a small diameter implant is that you start it in the right direction. So you really want to pay attention at the angulation of the adjacent teeth. And I use a large occlusal mirror, and I'm always looking from the incisal, so I can see that my direction is in alignment with the adjacent teeth, and I'm always looking at it from the facial to be sure it's not this way or this way, that it's lined up straight between these two teeth. You don't want to place the implant obviously into an adjacent tooth. So I'm marking the center of the socket, or the extraction area site, with this magic marker, just to be sure that I'm right in the center. Then I'm going to be careful to line the pilot drill with the adjacent teeth. Now, I'm not worried about drilling to a certain depth in the lower anterior, because you've got plenty of bone. If you drill a little bit past the depth, I think that's not bad. Now, I'm drilling to depth in this case. Remember, with small diameter implants, you don't have to drill to depth, because they bite and they seat themselves. They pull themselves into the osteotomy site or into the bone, just like a wood screw. The reason I'm drilling to depth is that if you just drill just through the cortical bone and then start advancing the small diameter implant, it may go off to one side or the other. So I want to create a channel for that implant to go into, so this pilot drill will be significantly smaller in diameter than the small diameter implant, so it'll just guide it into the osteotomy that I've created with the pilot drill. I'm looking at it from both sides. See, this is 16 millimeters or 17 millimeters. I'm just sure I've got it in the right direction. Then I'm going to take a radiograph of that. You also don't want to drill through the facial or through the lingual. So you may even take the pilot drill out of the handpiece and look at it from the incisal with the mirror to be sure it's aligned, the mesial, distal, and facial lingual appropriately, because you do not want to drill through the lingual part of the alveolar process or the facial part, and you don't want to drill into adjacent teeth. It's a pretty delicate drilling operation when you've got teeth in such close proximity. Okay, so see, we're good here. So when I'm and it may be an angulation issue, but when I'm placing the implant, as I screw it in, I'll kind of move the front to the top part of the implant to the cuspid side or the distal, which kind of moves it to the mesial, but that's fine right there. So this is a 17 millimeter small diameter implant. So you don't have to drill all the way to depth, but you want enough depth that the implant has a channel. If you haven't drilled all the way, it will advance itself in the apical part of the alveolar process to depth. This is a 2.5 times 17, and I'm going to advance it for a while. Then I'm going to take this wrench off and look at it from the incisal. It should be just fine because I have the channel that I'm screwing it into to guide it. So how far do you want to take it how far do you want to screw this in? I want the shoulder to be right at the gingival line. Now you can use two different types of small diameter implant. One is a ball clasp implant, and I mean it has a ball on the top, and the other one is for crown and bridge. Either one of them will work. So this has a ball, so I've got the shoulder right at the gingival line. You want to try to screw it in with the finger wrench, and if it will screw, it's not going to work. You want to have to advance it with either the winged wrench, also called the T-wrench, or the ratchet wrench. If you can screw it, advance it any further with the finger wrench, it's not going to work, and it's too loose. So I can't advance it, so that's good. They were not touching either tooth. We're pretty much right in the middle of the socket. We're trying in the flipper. You could go ahead and put a direct temporary on top of this and then squirt some bisacrylate around it, but I decided to stay with the removable flipper. Now this is the red impression coping, and what this is just some wax that I've dripped on the impression coping just to make it a little bulkier so the impression grabs it better. See, this is just to give it a little more bulk. So I pulled the impression coping with a polyether with custom tray impression, putting the flipper back in place. You have to actually cut a hole in the underside or the tissue side of the flipper to accommodate the ball of the implant. Here's the final crown. This is an Emax crown. I want my technician to give me this with every crown to know the crown has been treated as you treat an Emax crown. You can refer to the link of how to treat lithium disilicate Emax crowns prior to cementation. Now, if you have any tissue that's grown over the shoulder, you may have to remove that tissue. You cannot remove it with electrosurge. You'd have to remove it with a blade so that the crown seat's completely. Going to check the contacts, check the margins, going to wipe it with isopropyl alcohol once I've tried it in. Be sure there's no saliva on the tooth side of the crown. It's just a red rope wax carrier. Vaseline on the interproximal contacts. You're going to wipe the implant with something. You can wipe it with isopropyl alcohol, tubelacid, a lot of that water, just something to clean it. Then you're going to dry it real well. You're going to place, this is Unisim, hold it to place, floss it. Do not remove the excess cement until it has initial set, but do go ahead and floss it so you don't get any of the cement bound in the interproximal area. Now it has initial set, so I have to peel it off. You don't want to wipe it off, you want to peel it off. Then wipe it with a cotton ball. Check the occlusion. There it is, before and after. So that's the Dental Minute. These techniques work, and they work every time.
Are you feeling stuck? You know you have more to offer and you can elevate higher in your dentistry practice, but you just don't know how to do it? Well, great news. DentistryMasterclasses.com is here for you. At DentistryMasterclasses.com, Dr. Cutbirth is offering his greatest work and his best cases. Here's everything included when you subscribe to DentistryMasterclasses.com. You will get incredible comprehensive cases not seen in Dental Minute videos, an organized library of all the Dental Minute videos, and the Dentistry Masterclasses, comprehensive cases for study and reference. You will get before and after pictures of Dr. Cutbirth's fantastic restored cases. And guess what? All of this is $40 a month. That's right, $40 a month. This is an opportunity you cannot miss. Go to DentistryMasterclasses.com and subscribe today.